you very much to SARC 2021 and Dr. Joseph for inviting me to speak. I'm in London and I'm going to talk about Thrive and the journey so far. So my name's Anil Patel. I'm a consultant anaesthetist at the ENT and Eastern Dental Hospital, which is part of University College London Hospital. And I'm also the DAS Professor of Anaesthesia and Airway Management. I need to let you know that I've helped to develop a video laryngoscope. I've received travel, accommodation and consulting funding from F&P Healthcare, and much of my talk is based on the Optiflow Thrive equipment, and I'm also the trustee of two charities. So, nasal high flow, what is it? And how long has it been around? Well, actually, it turns out that it's been around for a very long time, actually. This is some very early images of nasal high flow usage in the 1960s. The principal issue at that time was the technology was not able to provide adequate humidification and oxygenation of nasal flow at specific set rates for prolonged periods of time. And actually it took another 20, 30 years for the technology to be able to deliver high flow oxygen, which is heated and humidified. And that really came about in the sort of 90s and 2000s. And that technology has been around for some time now, and it's been used. There are hundreds and hundreds of publications in high impact journals testifying its efficacy in terms of improvements in oxygenation and improvements in all age groups. So in terms of anaesthesia, really, I don't think many people knew about this, certainly when I was introduced to it in 2013. This was a technology that if you worked in intensive care, you were familiar with it. It had been around for about a decade or so, but it had never really transitioned over to the anaesthetic environment. And we were asked to have a look at it in the context of perhaps it would be useful for patients to recover from it, recover from anaesthesia with a high flow of oxygen, which is heated and humidified. And indeed, we did try that. And we also thought it might be useful for using it at the pre-oxygenation phase for induction of anesthesia. And in 2013, we started using it, and we published our data on that in 2015. And really, this was just a small series of 25 patients who were very difficult intubations for a whole variety of reasons. And we began to appreciate that not only was it a very useful tool for pre-oxygenating, but also for the apneic phase of anesthesia as well. And we coined the term Thrive, which stands for transnasal humidified rapid insufflation ventilatory exchange. And really the term actually describes everything. It's transnasal because it's going through the nose. It's humidified because the oxygen is warmed and humidified. It's a rapid insufflation because it's a very high flow rate, typically anywhere between 30 and 70 litres per minute. And the key is ventilatory exchange. We recognized, and other data has subsequently shown in some patient groups, that there appears to be ventilation taking place in a patient who is paralyzed and is not breathing. Therefore we coined this term. Now, in terms of its utilization, it can obviously be used, the technology can be used in the spontaneously breathing phase during induction of anesthesia, so as a pre-oxygenation tool. It can be used during apnea for maintenance, particularly during perhaps a difficult tracheal intubation or difficult airway management. And it can be used in the spontaneous ventilation during the recovery phase. I'm not really going to talk about the recovery phase today. I'm going to really talk about induction and maintenance, which is obviously of immediate concern to all of us. And if we break that down a little bit further, what we can see is that these are the sorts of uses that, since that original paper in 2015, that the technology has been put to use to. So it's been used as a pre-oxygenation tool. It's been used for sedation cases with patients breathing spontaneously. It's been used during general anesthesia in patients who continue to breathe spontaneously, particularly for the shared airway type of work. It's been used during apnea, again during difficult tracheal intubation and an extension of the apnea time. And then the extreme uses, I would say, the very advanced uses, where it's been used for extended apnea times, 10, 15, 20 minutes, 30 minutes, for actually operating on the larynx with an open field without a tracheal tube in place. And again, we can divide that really essentially physiologically into if the patient is breathing spontaneously, in which we tend to use the term nasal high flow or high flow nasal oxygen, and if the patient is apneic, in which there is different physiological mechanisms we believe taking place, and where we tend to use the term thrive, and where there's implicit in that term is a recognition that there may be some carbon dioxide clearance. And in terms of how we can look at this, we can look at this in terms of what is the best oxygenation? Is it nasal high flow? Is it a face mask? Is it other techniques? What gives us the best apnea time? So from the point at which we induce anesthesia, what gives us the best period in which we don't desaturate? What gives us CO2 clearance? And that's becoming increasingly clearer. There are certain patients that benefit and some patients that don't. And then, of course, the recovery phase as well. So again, just re-emphasizing, the terminology is sometimes confusing. Nasal high flow is breathing spontaneously. Thrive is apneic, not breathing. Now, I thought I'd give you some examples of just our clinical practice over the last, 7, 8 years now of using this technology. And this is a patient that I anesthetized way back in 2014 or 15. And I use it a lot because it really illustrates why I think the technology is so powerful and so useful, and why it's had such a major introduction into really all parts of the world. This is a patient. Radiotherapy, chemotherapy, or esophageal cancer.
Finished on the 31st of August.
Okay, so about 2 months ago.
Yeah.
Okay. And how long's the breathing been bad like this for?
2 to 3 days.
Okay. Can you swallow at all?
I can swallow. I'm not allowed to swallow any food or liquid.
Okay. Can you lie flat at all?
No, I haven't tried.
Okay, so this patient's got, as we can see from the video ringscope image, a tumour. He's had radiotherapy, and clearly he's in distress with stridor, and he's coming through the casualty department. Now, what you'll notice as soon as you put nasal high flow technology on, the stridor goes and his breathing improves significantly, and all the numbers improved. Respiratory rate comes down, oxygen saturations increase, PO2 increases, CO2 decreases. So he just gets to a much better place.
Breathing now.
Getting better. Is it better with that on or without it on?
With.
So this is a stridorous small airway patient who's in distress, and there's immediate relief from introduction of this technology. What's also very useful and very surprising is how much apnea time one can get in this group of patients. So this is quite tight, and there are 2 aspects to this. This lower airway, there's a small airway there, and there's a small. So you can see that the airway is obviously very narrow. Now, this patient's been anesthetized. He has had rocuronium, and he is not breathing. And the only means of oxygenation at the moment is Thrive. And this is a trainee intubating this patient with a very small microlaryngoscopy tube. And you can see that it's very tight to get this tube down. But she does eventually get this tube down.
Okay, so it's definitely dropped to... There we go. Okay, that's going no resistance.
Okay, just stop there. Good, and that is actually a minute added onto that, so it's 14.5 minutes. So that is 14.5 minutes of apnea before we were able to intubate this patient. And I don't know of any other technique that gives, in a stridorous patient in extremis, this degree of apnea time. And as as you saw, the saturations were 100% throughout that period. Now, this is not absolute, so no one is going to guarantee that you're going to maintain oxygen saturations through whatever you do in every patient, but I think it definitely adds an extra dimension to our airway management in these extreme circumstances.
So we're involved in a...
Now, this is another patient. This is a patient who, this is the anaesthetic chart of, and this time round we're undertaking laryngeal surgery. And you can see that this patient's been apneic for about 12
years. Parameters are all excellent. She's been thrived by the surgery. As you can see.
So we're operating on the larynx without a tube in place. She's paralysed. She's on a propofol infusion, and she's being thrived with 70 litres per minute. And we have a lot of experience in this group of patients. And I'll just run through, for example, a typical patient. So here's a patient who comes in with saturations of 96%. Anesthesia is induced, or rather nasal high flow is introduced at 30 litres per minute, and the oxygen saturations immediately go up to 100%. We then induce anesthesia at 9:10. She gets propofol, fentanyl, rocuronium, and she's fully paralyzed, has a propofol infusion running, and after the flow rate is increased to 70 litres per minute, and the surgeon operates, and it takes 20 minutes or so for the procedure to be finished on the larynx, and at the end of that, the end tidal CO2 is 6.1, which is measured by a laryngeal mask in place. And that's a typical sort of case. My own experience is approaching 1,200 patients now, and the average apnea time for the first 600 patients that we've looked at is just over 30 minutes. So we're very comfortable and confident that this technique works. It gives you a phenomenally extended apnea time. It's not absolute. It can fail, and you still need a backup plan of some form of oxygenation if for some reason the oxygen saturations fail. And we'll talk about what groups that can involve. I've put this slide in because it's from a few years ago now, but basically this is a summation of all of the apnea time in that group of patients. And basically, we've been operating on patients who've not been breathing, fully paralyzed for 21 days, if you add up all the time. And that is actually more than 3.5 times the time it took for man in the Apollo missions to get from the Earth to the moon. So we're pretty convinced that this technology does enhance the apnea time. And others have replicated that. So this is some work from Sweden, and this is some other work from London, which again have shown the extension of the apnea time that appears to be available with this technology. And there are other groups around the world that have shown similar sorts of expansion and extension of the apnea time, particularly during laryngeal surgery and during other types of surgery as well. We don't really have time to go into all of these, but it's just a flavour of the literature base that's been coming through since the original Thrive paper in 2015. Now, the pediatric group is very interesting. So in pediatric anesthesia, we are seeing an extension of the apnea time, but we're not seeing the enhanced CO2 elimination. And again, that's very interesting. So there appears to be, through pretty much every group, an extension of the apnea time, and in some groups, an increase in the CO2 removal. In other words, a sort of active ventilation taking place. So let's go back to this idea of the sorts of uses that the technology can be put to. So if we look at pre-oxygenation in spontaneously breathing patients, let's look at what do we do at the moment. So at the moment, we use a face mask and we pre-oxygenate, and we know that we get some extra time, some extra apnea time. If we use this simple low flow oxygen technique, so just 5-10 litres per minute of low flow nasal oxygen, first described and called nasal oxygenation during efforts to secure a tube, you get even more time for apnea than you do with a face mask. And if you use Thrive, I think you probably get the greatest apnea time in that group. Why should that be? Well, it's physiology, really. If you have X amount of oxygen molecules within the lung breathing air, then as soon as that's depleted when you're paralyzed, you'll start to desaturate. If you use a face mask and you fill that reservoir with more oxygen, you'll get an increased apnea time. If you expand, enhance ventilation perfusion matching, increase positive airway pressure, there'll be a greater oxygen reservoir. And if you use a nasal high flow, you'll also get improved CO2 clearance. You'll get washout of the anatomical dead space. You actually get improved pulmonary mechanics with reduced work of breathing and a reduced upper airway resistance. So again, all of those things enhancing the apnea time once we are paralyzed. Now that, interestingly, is the theory and what our observation is, but that hasn't been reflected in a lot of the literature. And if you look at some of the literature, what they're showing is that if you look at pre-oxygenation, and if your marker for pre-oxygenation is the end tidal fraction of oxygen, the end tidal oxygen that we measure with a face mask, then it appears that actually nasal high flow is not as good as a standard face mask. So that doesn't fit in. Why are we seeing this in the groups? And if we look at specific randomized trials that have compared directly face masks with nasal high flow, we're not seeing the improvements that we would expect to see. And indeed, here are some quotes. High flow pre-oxygenation performed worse than standard high flow rate face mask pre-oxygenation in healthy term parturients. Pre-oxygenation with high flow nasal oxygen is not a reliable method of pre-oxygenation before the induction of anesthesia. High flow nasal oxygen is inadequate to pre-oxygenate term pregnant women. Now, this is really interesting. Why are we seeing this and yet the theory and the observations are different? And I think the reason is because it's what we're measuring the end tidal fraction of oxygen. And sometimes we're measuring that by taking the nasal high flow on and putting a face mask on. And sometimes we're getting some problems with that measuring technique. But more fundamentally, what are we actually trying to measure in terms of end tidal O2? So let's have a look at this in terms of efficacy and efficiency of pre-oxygenation. What we're actually measuring when we measure the end tidal O2 is the efficacy of pre-oxygenation. We're measuring how quickly and how well we can get to more than 90% with a face mask breathing out. And these are the factors that determine that. What's actually important is the efficiency of pre-oxygenation, how long you get, and these are the factors that determine that. And this is a sort of a schematic to try and represent that. When we start pre-oxygenation, we measure the efficacy in terms of the end tidal FeO2 just before we induce neuromuscular blockade. But what is actually important is how long we get, and how long we get in terms of the efficiency, in terms of the expansion of the apnea time, is dependent on not just what the end tidal O2 is, but also whether you replenish those oxygen stores and what you're starting off with. So if, for example, if we look at alveolar ventilation and FRC in a pregnant woman, the FRC is reduced and the alveolar ventilation is increased. So we fill up that reservoir, that smaller limited reservoir, much more quickly, and therefore it appears that the efficacy is greater and therefore we should do really well. Except we all know we don't do well. We don't get an extension of the apnea time. Why not? Well, I think this is an attempt to try and explain all of this. Now, this is all the physiology that we all know. We know that it's not just dependent on the oxygen reservoir at the end of the pre-oxygenation, but it's also dependent on any mechanism that adds to that oxygen in the apnea phase. It's dependent on how well we uptake that oxygen. What is the oxygen delivery and the cellular uptake? And then, of course, the oxygen consumption. So in a pregnant woman, that is very high. And this, although the oxygen reservoir in terms of the end tidal O2 appears good, the actual amount of oxygen, the number of oxygen molecules is actually not very much at all, and therefore we get a reduction. So it's very important to understand why the end tidal O2 is a good surrogate marker, but it is not the absolute marker. And an example of that is here, really. This is Professor Andreas Schibler, whose mouth is closed, in which the nasal high flow rate is greater than the peak inspiratory flow rate, and therefore the FiO2 has to be 1. If it was not, and there was entrainment of air, then he would be drowning. Now, I'd like to go on now to talk about some very interesting data that's emerged over the last few years in terms of apneic phase, and what is better, and what is it, a small flow, an intermediate flow, or a large flow. Now this is a work that was carried out in Strasbourg in France, and this is data on large pigs, which were monitored with arterial blood gases, oxygen reserve index, and had their CT scans for lung atelectors and their MRI brain for brain damage. And these are the different, so these are 4 different categories of pig, which the blue is intubated and ventilated, the orange is 60 litres per minute, 30 litres per minute, 15 litres per minute nasal cannula. And what you can see very clearly, and obviously this can't be done in humans, but what you can see very clearly is that the higher the flow rate in apneic individual, in pigs in this case, the higher the flow rate, the longer the extension of the apnea time without desaturation. And indeed, there were deaths in this group, but none in this group. So this is animal work showing, I think, quite clearly that the higher flow rate enhances the apnea time and prevents the desaturation that we would see ordinarily. What about humans? Well, this is volunteer work, which looks at 0, 15, and 60 litres per minute. The black dots indicate that at 9 minutes, no patients desaturated. And you can see that in no nasal high flow, all these individuals desaturated. With 15 litres per minute, most of them desaturated, and at 60 litres per minute, none of them desaturated. So in humans as well, it appears that the higher the flow rate, the longer of the extension of the apnea time and the prevention of desaturation. This is in obese patients. And again, here, looking at either the light blue is high flow nasal, the blue is face mask, and the green is CPAP. And again, what we're seeing is that with nasal high flow, there appears to be a protective effect in terms of desaturation that we would see in obese patients. Excuse me. And this again was seen in this very interesting study that was done in Belgium, where obese patients were undergoing general anesthesia, and they were split up. So this is the face mask group, and this is the high flow nasal cannula group. And this is a measure of the change in the FRC as measured by the expansion that one can see in electrical impedance tomography. And plus means that there is an enhanced FRC, and negative means that the FRC falls. And what we see is that with face mask, with some positive pressure, and with high flow, there is an enhancement of the FRC. At the end of 10 minutes of apnea, one can see that the FRC has fallen much more in the face mask group than the high flow nasal group. So there appears to be some protection against the fall in FRC in obese patients with high flow nasal cannula as opposed to face mask pre-oxygenation. And that translates through to all of the high flow nasal patients having no desaturation through that 10-minute period, 600 seconds, and pretty much everyone in the face mask group desaturating around 250 seconds. And that translates through to these sorts of oxygen saturations. So I think there's really nice evidence coming through from animal model work, which we can take to the extreme, human volunteers, and in obese patients, that suggests that nasal high flow might be useful. And again, in EIT, looking at this technology, again, showing similar things. Now, in terms of apnea, in terms of breathing spontaneously, the technology is very useful for spontaneously breathing patients for fiber optic type techniques, and that was first described in this paper here, which showed dramatic improvements in the oxygenation, and indeed it's in the most recent guidelines for awake tracheal intubation in adults, and it's translated through to spontaneously breathing patients who are stridulous, undergoing general anesthesia, and for other procedures as well. And I think very importantly, if you have patients coming in who are in extremis, then I think it should be used. I think there's a very clear indication, and here are some papers that suggest that really it should be used in that group of patients where there are airway problems. Now, what's actually going on in terms of the physiology? Well, we know that there are really three mechanisms taking place. There is spontaneously breathing mechanisms, the so-called CPAP type effects, physiology, apneic oxygenation, and apneic ventilation. And if we look at the spontaneously breathing well, this is about dead space, washout, improving pulmonary mechanics. So that is all the physiology that's taking place during pre-oxygenation, during spontaneously ventilating techniques, during awake tracheal intubation. Anyone where there's some degree of spontaneous breathing, that's the principal mechanism that's enhancing oxygenation and CO2 clearance. When we're paralyzed and still, there are two mechanisms that take place, and I'll talk a little bit about those. Now, originally, we thought that it's principally apneic ventilation, and I think in some groups that is still the case, but we're beginning to appreciate that that isn't taking place in all groups. So, for example, in children, it's apneic oxygenation that's the predominant factor. In other groups, it's apneic ventilation that's the key. So, apneic oxygenation, the simple idea that when you're paralyzed, it's a concept that's been known for many, many years, that you use oxygen, therefore you reduce the pressure within the lung, and you enhance the transport of oxygen from the mouth and the nose and the oropharynx down the airway into the lungs. So you're replenishing the oxygen stores in the lung. What about apneic ventilation? Well, we thought apneic ventilation was taking place because very early on in 2015-16, as we plotted our apnea time, we saw this sort of curve in terms of CO2 rise, when all the data suggested from the historical data that this is the rise we should have seen. Therefore, it suggested to us that there was some CO2 clearance mechanism taking place. And that was replicated in other papers as well, with arterial blood gases showing a similar increase in CO2. Obviously, this is a little bit more because we're measuring arterial blood gas rather than necessarily end-tidal CO2. And other groups, so this is Alistair McNarris group in Scotland, showed a similar rate of rise, and this group in France showed a similar rate of rise. And this is our data. And what we appeared to show was that with Thrive, compared to historical traditional low flow techniques, we were seeing a greater CO2 clearance. And what does that mean? Well, it means in terms of its clinical aspect. I mentioned to you earlier about how we run microlaryngeal operations on the larynx in anesthetized paralyzed patients for prolonged periods of time, up to sort of half an hour or so. And we're very comfortable with that. And indeed, we've done many thousands of those. This is probably a more direct clinical relevance for most people. Somebody comes in, they've obviously had radiotherapy, they've got a very difficult airway, they've got a big tumor, they're extended. How do you manage them? What do you do? How do you extend your apnea time while you manage that airway? And this is that patient. This is on air, the PO2 is 10. At the end of the pre-oxygenation with nasal high flow Thrive, we're seeing a blood gas of PO2 of 68 kilopascals. And interestingly, it took 20 minutes to get the tube down for a trainee under controlled, stable conditions. And the PO2 was still 33, and the PCO2 and the end-tidal CO2 is here. So that's the sorts of use where it's really useful. In terms of how does it work? Well, there's been a lot of work done over the last few years. This is showing that obviously there is CO2 clearance, just like you would see in spontaneously breathing patients, in apneic paralyzed patients, so with Optiflow Thrive. There's been a lot of work done in both modeling and in computational fluid dynamic modeling around what is that mechanism. And what we're seeing is that we're seeing a lot of flow at the top end. We're seeing movements, supraglottic flow vortices around the top of the larynx. We're seeing that here, although everything looks still. When you see a piece of string, it's moving. That translates through to within the airway, flow vortices that get transmitted down, and superimposed on that are the cardiopneumatic movements, which you'll just see in a moment coming through, which is the heart pump mechanism, the heart moving, and that movement, that combination of supraglottic flow vortices clearing the upper airway and the upper trachea and the carina, along with cardiogenic movements, which is pumping some of that CO2 out in a paralyzed still patient, is meaning that we are in paralyzed patients still seeing some CO2 clearance. And another way of looking at that is just simply, this is no-thrive looking directly it within the airway. In terms of trials, there's a lot of trials going on, as you can imagine. Some interesting ones around rapid sequence intubation, again showing this essentially the superiority of Thrive versus our perceived gold standard face mask. So nasal high flow Thrive gives you more less fall in oxygen saturations after induction of anesthesia and paralysis. Closing up now, just some limits. As I said, this is not absolute, it is not guaranteed, but patients can still desaturate, and you need to have be aware that that can happen in total airway obstruction. In certain patient groups, we're realizing particularly supermorbid obesity, and that there is clearly a learning curve to all of this in terms of basic, intermediate, and advanced use. I've written this in red because I think it's very important that we appreciate this is not a rescue tool for desaturation. This is a tool to prevent us from desaturating. If we do desaturate, then we need significant positive airway pressure and re-expansion of the lung. And like everything in airway management, whatever tool you use, our brain is the best tool that we have in it. So this is not a substitute for good airway management and planning. So in summary, in terms of what is best in terms of oxygenation, apnea time, CO clearance, in terms of pre-oxygenation, although much of the data, because it's only measuring end-tidal O2 and because it is not able to measure extension of apnea time in a way that some of the trials I did measure, I think actually oxygenation and pre-oxygenation is superior and gives a greater apnea time with nasal high flow Thrive than it does with face mask ventilation. I think it's very useful for sedation and indeed around the world, it's pretty much the standard tool for sedation, particularly for awake tracheal intubation techniques, particularly amongst the experienced users. It is, I think, a very useful tool for the apneic phase for during laryngoscopy and intubation, and as an advanced tool, it has applications for extended apnea times in laryngeal surgery. But that is a very advanced tool that only some people are going to be able to use. Its real application is in this initial tranche of uses: pre-oxygenation, sedation, and during the apneic phase around direct airway management. So I'll finish there. Really, that's the journey so far. We still have a lot to learn, but we've learned an awful lot from a position in 2013 when we first got the technology, where we didn't even know what it was, where it's been introduced into guidelines, many guidelines from many countries around the world. It's clear from the literature that it provides exceptional pre-oxygenation. It's clear that it is for many of us, it is the optimal use of extension of apnea time during difficult intubation, and it has applications at the extreme end of the spectrum for certain laryngeal procedures for a small subgroup of patients. We have a lot more to learn. We know that there are patients in which it appears that for example, the pediatric group, where we're not seeing the CO2 elimination, and that may be true in some adult population groups as well. So we've still got a lot to learn. We've learned a lot about the mechanism, and the mechanism appears to be supraglottic flow vortices superimposed on cardio-pneumatic oscillations, and that appears to eliminate some CO2 and increase the oxygenation of the patient. So I'll finish there. It's been a really exciting journey. We've learned an awful lot in the last 7-8 years, but we still have much to learn. Thank you very much.